Okay, so I hope you're ready because as promised, we have a big video planned for today. This video is hypoglycemia complication of diabetes. So we're not talking about non-diabetics, we're specifically talking about diabetic patients and the complication of hypoglycemia. Now, if you have purchased any of my packets, you might remember that the Oh My God packet lists hypoglycemia right on page 7 as one of the reasons to see a patient first, right? So you know this is page 7. On page 7 are all the people you should be seeing first. You may remember that the Oh My God page 6 lists hypoglycemia as a definite reason to see people first in our little NCLEX quickie. There it is under letter G. So if you look at letter G, it says tachycardia and of course hypotension, and then the hypoglycemia as one of the top reasons to see somebody first. So in other words, hypoglycemia is a medical emergency. And let me just say that hypoglycemia kills more people than hyperglycemia, which is why it's in this Oh My God packet. Now, that being said, if you have the entire self-study program, then we will be working out of the diabetes packet and we will cover several of the pages. We will be covering, for example, the page that has, of course, the hypoglycemia on it. So let me just make sure I show you that. It's a decent packet, probably one of the best packets you could have. So you have a page that says hypoglycemia. We're going to talk about that page. The very next page after that talks about hypoglycemia. You will need probably 2 pages to take all these notes on the board behind me. And then we're going to use the page that talks about glucagon, all right, because that's the treatment for hypoglycemia, one of the treatments. So now that you have your materials with you, understand that this is a very critical video if you are taking the NCLEX exam, if you are trying to pass your HESI or your ATI. Hypoglycemia as a diabetes complication is huge. Also, if you're in nursing school, you probably already figured out that if you go to my playlist on this HETV channel, everything you need, 500 plus videos, every subject you can imagine is right there for you to pass any test they give you. So let's get started, shall we? First of all, it's the who, what, where, why, and how of this lecture. So we kind of start off trying to explain some difficult concepts on a very basic street level because I like to keep it simple, Shirley Temple. So here we go. Hypoglycemia, emergency, oh my God, what is it? Well, of course, it is a blood sugar less than 70 milligrams per deciliter. If you live in Canada or London, then we're talking 3.9. So you know your measurements are a little different. For those of us in continental USA, we're talking a blood sugar less than 70. Now, it can be severe, and severe is a blood sugar less than 50, and we got a whole nother ball game with that, and we will cover that, but let's just tackle it head on with the blood sugar less than 70. And then we need to really be aware as nurses and physicians what could cause hypoglycemia. So when we look at the causes of hypoglycemia, number 1 is insulin, hypo. I hope I said that right. When we look at the causes for hypo, whoa means low, whoa, right? Hypo anything, hypothyroid is slow, low, and cold. Hypothyroid, hypoglycemia, low, okay? So when we look at the causes of hypoglycemia, We know that the number one cause is a patient who is taking insulin and or oral or PO hypoglycemic medications. Now, if you just know common sense and you start thinking about the difference between a type 1 diabetic and a type 2 diabetic, you know the biggest difference between a type 1 diabetic and a type 2 diabetic is the fact that the type 1 diabetic will be taking insulin injections until they die, or they die, right? So it's not like an option. The type 1 diabetic does not produce insulin, so they will be on insulin injections until they die, or they will die, okay? So that means since insulin is the number one reason for a lot of hypoglycemic episodes, that natural assumption, accurately so, is that we see more hypoglycemic actions or situations with our type 1 diabetic because they're all on insulin. Now, the number one cause of hypoglycemia in the type 2 diabetic is actually taking oral hypoglycemic medications. An example of that would be any kind of sulfonylurea, glipizide, glimepiride, whatever. Some of those sulfonylureas are medications that stimulate the production of insulin from the pancreas. So a type 1 would never take oral hypoglycemics because their pancreas can't be stimulated to do anything. But a type 2 diabetic who is on sulfonylureas, which is why we don't like to use them as much, can definitely have episodes of hypoglycemia. Now, so we know that if we look at insulin, there are many different types. There is the rapid, which is like Lispro, Apidra, whatever. There is the short, which is your regular. There is the intermediate, which is NPH. And there is long-acting, which is Glargine. And you just need to know it's typically not the Glargine. It's not the long-acting insulin that is at fault, not usually, okay? All right, now, we already talked about the PO or oral hypoglycemics, and that is, again, an example of that would be your sulfonylureas, okay? When you're on those, they definitely have a high incidence of low blood sugar. But another one that's actually a really good thing is exercise, especially aerobics exercise. Did you know, for example, which again is a good thing, that any type of aerobics exercise can lower the blood sugar for up to 24 straight hours? So in this situation, we love that you decided to exercise, but we need our patients who are diabetics to check their blood sugar before, during, and after exercising. And then always have a 15-gram carbohydrate snack that they take right before exercising within that half an hour. So let me explain what a 15-gram carbohydrate snack would be. Here we go. It could be 4 ounces or a half a cup of pop or juice. That's simple. It could be 8 ounces of skim milk, and chocolate milk is a great one. It could be 4 teaspoons of sugar. I think I'd throw up, but hey, it's a 15-gram of carbohydrate. 1 tablespoon of honey. That might not be too bad. 5 candies, Lifesavers, diabetic candies, or pills. They're diabetic sugar pills made for this reason, or any real candies, like anything really, candy, right? Okay. Or here's one you might not have known: 6 saltines or 3 graham crackers. So these are examples of 15 grams of carbohydrate that you should take, or at least consider it based on your blood sugar. You should consider doing that before you exercise. Also, we say don't even think about exercising unless your blood sugar is somewhere between 100 and 250. Do not exercise if it's over 250. Do not exercise if it's under 100. Alcohol is confusing to most people because most of us know that like alcohol is a sugar. So then why is it on my list of causes for low blood sugar? Why is it on the list at all for hypoglycemia? Well, the problem is alcohol, whenever we drink it, it is considered a poison or a toxin to the liver. In the human body, that's just what it's considered. I mean, you might like your Hennessy and you might like your Jack, but that is what it is. It's a toxin or chemical to the liver. So the liver's job, if you remember, is to detox the body of chemicals. Well, this alcohol is such a serious chemical toxin to the body that the liver prioritizes getting rid of the alcohol as the highest priority that the liver could do. So some of the other functions of the liver take a back seat. Now, if you don't know the other functions of the liver, this is going to be a little confusing. So let me remind you, one of the other functions of the liver is to store sugar as glycogen, right? So everything you eat goes either in your muscles or your bloodstream or to your liver. Any glucose is going to go to the liver. The leftover glucose is going to go to the liver to store for you while you are sleeping tonight, or if you start fasting, or if you have any situation where the blood sugar is low, we got this backup plan in our liver. Ooh, the problem is when you're drinking and not eating, the liver prioritizes detoxification of the alcohol out of your body. It prioritizes that over the storage of sugar. Because what's more harmful? Well, alcohol sitting in your body, alcohol, blood poisoning. So it does its job that way, but it can't do its other job, which is to store the sugar. So what ends up happening with alcohol being a sugar, it triggers insulin, and insulin does its job, and it takes your blood sugar and makes it super, super, super low, and there is no backup plan because you didn't eat while you were drinking. So what do we say? There may be a reason why a lot of bars have beer nuts on the counter, because they get it. They know you can't just drink and not eat. And the key is really eating before you go out doing this nonsense. Or how about just not drinking at all? Works for me. Try it. I mean, I drink sometimes, but it's not a regular thing. And if you're a diabetic, really be very careful with this whole drinking thing, okay? Aspirin and sulfonylureas and sulfa drugs can lower your blood sugar. It's not the most common reasons, but you do need to know that it does lower blood sugar. A patient who has had a situation where they were prolonged NPO status. Maybe they were supposed to have surgery today and they were NPO after midnight, and that kind of got bumped to tomorrow. So they kept them NPO. That patient's at a very high risk for hypoglycemia. Maybe, like in my department, the patient was very, very, very compliant. They did their bowel prep to get their colonoscopy. They did the clear liquid diet before, and maybe they only had diet drinks to drink for their clear liquids, which don't have sugar. So they were drinking their clear liquids a couple days before, and then that very next day they were NPO and did a bowel prep. I have seen it in my department where the blood sugar is pretty low. So remember, prolonged NPO status. We have two more on the board. One of them I'll tackle out of order, and that's gastroparesis. And you know, anytime I say gastro, you got to remember gastro means stomach. Paresis, which means weakness, just put the two together and sort of you got a situation where you understand that the stomach and the gut does not move food very quickly. In fact, food just kind of sits around and keeps stimulating insulin, and insulin keeps coming and decreasing the blood sugar. So the patient with gastroparesis is usually someone who's been a diabetic for a very long time, and they may have something called hypoglycemia unawareness, so that not only does food stay in the gut, like you have what we would call a delayed gastric emptying, decreased peristalsis, but also if it's that bad, it means that the nerves in the GI system don't work, and those same nerves are the nerves that would tell you your blood sugar's low. So that patient may have a hypoglycemic unawareness, and that just means that you don't even know when your blood sugar's low. So if you don't know that it's low, how could you possibly act on it? I hope that makes sense. The big one here is that beta blockers are on my board. They do not lower blood sugar, but what they do is they mask hypoglycemia. So if you think about the classic hallmark signs of hypoglycemia, like sweating, shaking, irritability, and a bunch of other stuff, tachycardia, you know that with beta blockers, it blocks the stress response. Well, when you have hypoglycemia, you activate the stress response. But if you're on a beta blocker, you are blocking the stress response, so you don't get the shaking, you don't get the sweating, you don't get the tachycardia, you don't get the feelings that tell you my blood sugar might be low. So we know that while beta blockers don't lower blood sugar, they absolutely do mask hypoglycemia. And for some patients, their doctors don't even want them on it. So we say caution whenever using beta blockers in diabetics. And for some, they may be completely contraindicated, okay? You got to know that. So that led right into one big problem that might be causing a patient's blood sugar to go down. But it's very confusing because they can't catch it if they're not careful. Here's what I mean by that. I said that insulin is often the #1 reason why blood sugar is so low, and we've got this hypoglycemia. There is something called the Somogyi effect. Let me say that again. Somogyi effect, okay? So SOMO means your blood sugar is so low. But the Somogyi effect is at night. In fact, it's in the middle of the night, like in the middle of the night, like at 3 a.m., like who would know that? And then how does this even play out? Well, this patient's Somogyi effect is due to insulin, one insulin or another. Maybe it's the long acting, maybe it's the intermediate acting, maybe it's the short. One of their insulins or more is too high. Very often we see this the newly diagnosed diabetic. So perhaps we don't have their insulin amount quite right yet. We're playing around with a couple doses. Well, with the Somogyi effect, Somogyi, the blood sugar is so low at night, specifically around the 3 a.m. hour. This is a result of too much insulin, but they would not know it necessarily, except for in the morning they have an extremely high blood sugar, because by then the liver has kicked in to correct the low blood sugar. We just talked about the liver and the role it plays when you're sleeping. It keeps your blood sugar cool. Well, the liver has released glycogen, causing the sugar to go up by 6 a.m. in response to this so low blood sugar at 3 a.m. And what we say about that patient is very often they have nightmares. They wake up feeling terrible. they are at very high risk of a cardiac event like a heart attack, or even some think strokes are related to this. So we know that with this patient, we have a few things we must do. Number one, we've got to talk to our doctors or nurse practitioners about the fact that this is going on, and you wouldn't know, but you would know that your sugars are really high in the morning, and that's reportable. The patient can also take a snack at night that has a protein and a sugar attached to it. Let's give you examples. Cheese crackers, peanut butter crackers, turkey sandwich, anything with the meat and a carb is really a fun snack. But I remember being a nursing assistant way back in the 80s, and I remember working at a long-term care facility, a skilled nursing facility, and I swear I remember passing out turkey sandwiches at 10 o'clock at night for, now I know, this reason. So a snack at night with a protein and a carb. And I want you to know that this is very serious, because we know that 50% of patients with diabetes will have low blood sugar episodes at night. And like I said, it increases the risk of strokes and heart attacks. So that's important, because the brain cannot make glucose. So when that blood sugar dips below, we're having ischemia in the brain. Hello. Oh boy. Now, how else would we know that this is so serious? This patient's having this and that and the other symptom. This is kind of easy. And of course, everybody around town knows the mnemonic that we often use. We say, here, how would we know? We say that the symptoms the patient's going to have are autonomic neuro symptoms. Those symptoms, we have a mnemonic that says, cold and clammy, give them candy. Cold and clammy, give them candy. Cold and clammy, give them candy. Y'all got it? Now, the opposite is true with the other guy, right? If the sugar's high, we say warm and dry, your sugar is high. Warm and dry, then your sugar is high. This is cold and clammy, give them candy. I hope you got it, because I'm doing a whole lot up here. Now, so let's look at some of the words you might get on your test, because that's the problem. Some of y'all see, but you don't really see what's happening on the test. So we want all the different ways to say the same shit, right? Here we go. There is the word sweaty. There is the word clammy. What else could they say? Diaphoresis, diaphoretic. They could say perspiring, right? They could say doughy skin, right? Yeah, you gotta know all the ways the test will throw the shit right at you and you didn't catch it at all, okay? So sweaty has many different ways of, coming at you. The patient is shaky. What's the word that might show up on anybody's test? Tremulous. Ain't that some bullshit? That sounds like a little $5 word, don't it, y'all? Yeah, I don't know what that is, but you know now it's shaky or tremors, right? Tremulous. All right. Irritable, confused, anxious. Those are behavior terms. Do you remember in our Oh My God packet on page 6, I told you the worst thing your patient could do, and the number one reason to see them first and prioritize them higher than anybody else, I told you would be because of, here we go, behavior changes. If you turn to page 7 after page 6, I put all the little words that mean behavior changes up here. See that? Agitation, restlessness, anxiety, irritability, on and on and on. Now, that's important because the brain needs sugar in order to use oxygen. So your brain is not getting much sugar or oxygen, and so you are showing up kind of funky, right? This patient could even be a little combative. Like, you have to remember that all goes together. Here's another one, vision changes. Some patients will define it as blurred, but typically it's really double vision because you see more blurred vision with high blood sugar. But I don't care. Whatever complaint your patient has about their eyes, that's what matters, okay? So vision changes, they're gonna have a hunger headache because they're what? Hungry. Their heart is gonna race. They're gonna have palpitations. They may even say it feels like it's pounding out of their chest. Their color is gonna look weird. Maybe they'll be pale because low blood sugar causes a very serious vasoconstriction from the stress response of epinephrine. So maybe they're pale or ashen. I have had patients tell me their mouth or their face was tingling. It was tingling in their lips or their mouth, and that caused them to have a little difficulty even talking. Like the patient can't really talk the way they normally do, and so they come across having difficulty expressing themselves. Even concentrating at all is hard, okay? A word that you might want to remember, might be on a test somewhere. Obtunded. Yeah, that patient is drowsy and out of it, barely arousable, maybe to painful stimuli. Obtunded, only arousable to painful stimuli. Ooh, I don't want no obtunded patient, honey. That don't sound right. Now, in red is the word obtunded, and in red is drowsy, seizures, coma, and death. You let that blood sugar dip below 40s and see what you get. Because, you know, less than 70 was hypoglycemia. You go below 40 and we're going to have all of these or any of these or any number of these at one time. You get what I'm saying? That's pretty severe hypoglycemia. I think the lowest I personally have ever seen, and I really know that that was accurate, was 32. And it was, you know, it was pretty bad, but we got them around real quick here. All right. So we've done what? We've defined it for you. We talked about the causes of hypoglycemia. And we talked about the signs and symptoms of hypoglycemia. And let me just say this for the record. Patients with frequent episodes of hypoglycemia are very much at risk for strokes, heart attacks, and cardiac arrest, not to mention some dysrhythmias, okay? Let me say this as well. To prevent patients from having hypoglycemic episodes that they're totally unaware of, because you can't prevent all hypoglycemia, but in order to catch it early, we know that if a patient does not have continuous glucose monitoring, that little gadget on them, the Libre or whatever, if they don't have that at all, then you better believe that they need to check their blood sugar 5 to 6 times a day. Here's an example. Before any meds like insulin or medications that could lower the blood sugar, before meals, fasting blood sugar when they first wake up is always very beneficial. And then right before bed, and anytime they have signs and symptoms, okay? All right, now, so we've done that. Now we're going on to our last part of this video. The last part of the video is the treatment for hypoglycemia, the complication of diabetes. The treatment must follow a 15-15 rule. Let me explain. Always check blood sugar first. Did I make myself clear? Hey, wake up. Always check blood sugar first, boo. Always. Ain't no ifs, and what's, or buts. I said always. Okay. Now, a mild hypoglycemic episode, which is a blood sugar less than 60, gets 15, there's that 15-15 rule, 15 milligrams of carbohydrate, Then check the blood sugar in 15 minutes. If the blood sugar is higher than 70, feed the patient protein and carbohydrate combined. So if it's not higher than 70, repeat this whole treatment with the 15-gram carb until it is. Now, this little program, if you will, of 15-15, I call it this: check, blood sugar, treat, 15 grams, check, again, 15 minutes later, and eat a meal. So check, treat, check, and eat. Check, treat, check, and eat. Y'all got it? Okay, all right, now let's move on. We're almost done. Here we have number 2, moderate to severe blood sugar less than 50 with no IV, but the patient can swallow. Well, you're gonna have to follow above just what you just did and then be trying to place an IV yesterday, nurses. Of course, this is in the community, right? Now, also, that's in the hospital, right? If you're not in a hospital where you could place an IV right away while you're going through this nonsense, make sure if you're in a non-hospital area, you call 911 and treat this guy, but you call 911 while you're trying to get this blood sugar up, or you're going to be here by yourself with somebody that could have a blood sugar that's just going down quickly, and we don't even have any help, okay? The unconscious patient is simple. We're not giving them anything to eat, right, or drink. No, we are going to give them glucagon, because if the glucose is gone, we give glucagon, all right? Look, when the glucose is gone, give glucagon. It's that simple. IM, sub-Q, or IV. Now, remember, we must feed this patient as soon as possible. So when they regain their consciousness and they're able to swallow and eat, we need to feed them as soon as possible, because this is going to cause, this glucagon that you gave can cause rebound hypoglycemia within about a half an hour to an hour. So as soon as they can eat, feed them, okay? When we give glucagon, make sure you monitor for nausea and vomiting, which could cause the patient to aspirate. And so we keep this patient in a sideline position, because the patient can get pretty sick off of this glucagon. Also, we know that when we give glucagon, we might be lowering the potassium, and glucagon can cause extravasation. Now, I don't know if you remember what extravasation is, but it is the infiltration of a hyperosmolar or concentrated solution, and glucagon IV push can cause extravasation. So you're watching that IV site. We would love to give it through a PICC line or something like that, but hey, you gotta do what you gotta do. This glucagon, remember how it works. It stimulates the release of glycogen from the liver. This is called glycogenolysis. Uh-oh, hold on now. What does lysis mean, y'all? Come on, what does lysis mean? It means the destruction of, okay. Glycogen is what the liver stored for you to use when you were sleeping. We need to get the storage broken down into glucose. So we call it the destruction or breakdown of glycogen, so we can get the glucose for the bloodstream and the brain. So that is glycogenolysis. I hope you heard me. Likes to be on a test sometimes. All right, now, number 4. What if we're unconscious, but we have an IV? We not finna mess around with nothing but the straight sugar, baby. We're gonna do D50 in water. IV push, super slow. Again, a PICC line would be better, or central venous catheter would be ideal, but hey, it is what it is. We're gonna have to give this guy some D50W IV push or IV infusion. And this needs to be super slow because just like that glucagon, it is very caustic to the blood vessel. Now, so what did we do? We talked about what hypoglycemia is. We talked about the causes of hypoglycemia. We talked about the signs and symptoms of hypoglycemia, and we concluded with how to treat hypoglycemia. So I hope you learned a lot. To those of you who are joining me this weekend for boot camp, remember we have negotiated cheaper hotel costs, more affordable hotel costs. Remember, bring your smile because it's very fun. And for 3 days, you and me in Cleveland, Ohio are going to kick ass and take names. I can't wait to see you and hug you. Deuces until we meet again. Bye-bye.